sound of silence surrounding me like a symphony without a score, a perfect storm without a shore. I wanna hear your voice calling out my name, a life-changing noise. I'll never be the same. Let's hear the world like you never did before. Hear the world, let's open up that door. Hear the world, it's time to lend a helping hand. We hear the world, I hear the world loud and clear. I feel this music instead of tears. I hear the world, no ifs and whys, the chant of birds up in the sky. And I hear your voice calling out my name. Now I'm like you and you're like me, we're all the same. Let's hear the world like we never did before. Hear the world, let's open up that door. Hear the world, it's time to lend a helping hand. Everyone sing out across the land. Raise your voice for those who can't be heard. Speak out loud, put out the word. Hear the music, hear the word. 'Cause love is all we need. Let's hear the world. Hear the world. Let's hear the world. It's time to lend a helping hand. Everyone sing out across the land. We hear the world.
Hello everyone, thank you so much for coming. It's really a pleasure to see our event after all these preparations over months, so we see the day actually. So thank you so much for registering and for coming in this very fabulous weather outside. So our aim actually for this day is to learn something new, to network and celebrate this very special day for hearing health. And please enjoy it. It's a really pleasure to allow for Professor Peter Bauer, our center lead, to open the event. Thank you.
Thank you, Salwa. Can everyone hear me okay? Okay, thank you. So, as Salwa said, thank you for the introduction. My name is Pete Bauer. I lead the Centre for Primary Care and Health Services Research, which is in the Williamson building just over the road. And it gives me great pleasure to introduce this event today. We recently put in a bid for some NIHR infrastructure. We were kind of encouraged to think about what we do. And one of the things that we came up with was a kind of a grand plan for our department and a single aim. What do we want to do? And we said we want to understand how we can safely manage the health needs of an ageing population in primary care. So very broad, but related, focused on safety and ageing. And that's what we want to do. Now, thinking about that work, we tended to think about clinical issues. So we think about diabetes, where we have expertise. We think about depression, where we have expertise. We think about other chronic conditions where we have expertise. Increasingly, because the NIHR is interested, we start to think about frailty and multimorbidity, these being really important issues. But in being invited along today, I realised that we really don't give a lot of attention to issues of hearing. And sensory issues generally. We tend to think in clinical areas, we tend to think about service design, but this really important issue about hearing health, we have really underestimated and lack of focus on this for a long time. And it's strange because we work in primary care, and primary care is all about communication. It is one of the fundamental issues that drives patient satisfaction, it drives patient complaints. When patients complain about primary care, it's about communication, about an ability to understand. And we're interested in patient-centred care and holistic care. You can't do shared decision-making unless you can communicate effectively with patients. So it's been quite a surprise thinking back about we've just really not looked at hearing health more generally. And that's why it's really nice to come along today to this event to remind ourselves that hearing remains the most prevalent untreated sensory issue in the community, and one of the third highest chronic health complaint amongst patients, the patients that we're trying to serve through our research. So it's a great opportunity for us to think again about what we're doing and how we're going to take that forward. So it's a great pleasure for that reason. The second great pleasure is because this has been driven by early career researchers, and I'd just like to say well done to Dalia and Salwa, who came to me a few months ago and said we want to run this event, and have driven this through. And don't underestimate how long it takes to organise something like this. It takes a long time. It takes a bit of passion. It takes a bit of drive. And I know there's lots of volunteers from our department and other departments who are helping out today, so thank you for that as well. But we're just really pleased. I mean, what we do in the future as a research department is really dependent on our early career people who come with ideas about how we should be taking things forward. And so we're really pleased that Dalia and Salwa have led this, and hopefully this will be the first stage in bringing hearing health front and centre into what we do in the Centre for Primary Care. So thank you for doing that. So you'll see the structure for the day. You've got some really good talks coming up, looking at the life course in relation to hearing health, ageing and healthy ageing and how that's affected by hearing health. And it's great to see that we're going to hear a little bit about the priority setting partnership in hearing health. As you all know, the NIHR and most funders are paying much more attention now to making sure that research is aligned with the needs of patients. And to understand those needs, you need to talk to patients, and the PSP and other priority setting partnerships have done a really good job in allowing patients to have a voice at the beginning of setting research strategy. So it'll be really interesting to hear those issues today. After all that, of course, probably the most important thing is the discussions and, of course, the networking afterwards about how you're going to generate collaborations and take this work forward. So I'll be really interested to see what comes out of that. So I'm really sorry that I can't join you for this. I've got something far more tedious to go to that I have to sit through this afternoon that was planned well in advance. So I can't join you for the rest of the session. But I really hope it goes well, and I really look forward to seeing the results of this in terms of your ideas about how we can take this forward and maybe make this more of a long-term project, not just today, but how we can make it a long-term project so that we really do something around hearing health, which is an area, as I say, we've not really focused on before. So, enjoy the day. Congratulations to Dalia and Salwa for getting this far, and I hope the rest of the day goes really well. And I very much look forward to seeing the results of all your discussions. So thank you very much.
Welcome everyone, and thank you for coming. I'm so pleased you're here today to celebrate together the World Hearing Day. A day that is important for more of 460 million people with hearing loss across the world, and for those with whom they communicate. Also, this day has a special meaning for me, because on that day, exactly 10 years ago, in 2002, something happened that would change completely my life. I was studying for a certification in Greek Sign Language, and the Health Federation had organized a party on the day. After the end of the party, very late in the night, I received a text. It was from my sign language teacher who is deaf. As we are close friends and all her relatives were living in another city, she let me know that she was in the emergency unit of a hospital with her 5-year-old daughter who had severe abdominal pain. As it was very late, she couldn't find a sign language interpreter, and she kindly asked me to go and provide some basic interpretation in sign language in the hospital. I went to the hospital where I found her really frustrated because she couldn't even communicate with the receptionist to explain her daughter's issue. We took a number, we were waiting together in the waiting room, and then I realized that once her turn had come, she didn't understand, and no one from the staff informed her, being completely unaware that she is deaf. We walked together then to the consultation room. I provided some basic interpretation in sign language, and she was noting that she understands the medical instructions. But after the end of the consultation, I realized that not only she didn't understand the medical diagnosis and the instructions, but also how to give properly the medication to her daughter. And she asked me to explain her again the diagnosis and the instructions that the doctor gave to her. That experience shocked me and moved me, and I saw firsthand the multiple barriers a person with hearing loss faces in the access and the use of health services. And I decided on that day that I wanted to identify these barriers and to address the complex health and care needs of this population and find solutions. And then I decided to follow up my studies to a master's and PhD level. I used the phrase complex health and care needs because hearing loss does not affect only the ear structure with deterioration in the ear, but also the related activities, the speech comprehension, and the participation of the individuals in society, with, for example, engaging in employment, receiving education for health issues, participating in social events like this, or receiving health services. So a primary healthcare approach is more important than ever because primary care is not concerned with treating specific diseases or conditions, but adopts a more person-centered perspective. The primary care addresses the wider determinants of health and meets people's hearing health needs during their life course. This perspective will inform my today's presentation, which has the title, Why Hearing Matters, Preventing and Addressing Hearing Loss Across the Life Course. I'm going to cover 3 points. First, how hearing loss is influenced by socioeconomic and lifestyle factors, the role of primary care in the early identification in access to secondary care, and the links of hearing loss with other chronic conditions, and how that affects the patient's safety. Hearing loss is a major global health challenge. Today, over 460 million people have disabling hearing loss, and the numbers could rise to over 900 million by 2015 unless action is taken. In the UK, hearing loss is also a major public health issue, as more than 11 million people have hearing loss, which translates to 1 in 6 people in the UK. And it's estimated that by 2035, more than 15 million people will have hearing loss, 1/5 of the population. Historically, hearing loss has been conceptualized as an impairment within a biomedical model and managed clinically within an isolated model of care. However, hearing loss is far beyond a sensory impairment, as has many physical, social, cognitive, economic and emotional consequences and affects largely the quality of life. It is the third most common chronic health condition after high blood pressure and arthritis. 1/3 of people above 65 live with disabling hearing loss, and we saw the health profile for England that it is the first leading cause of morbidity among adults 70 years and older, and the second leading cause among adults 50 to 69 years old. However, there is evidence that a number of the factors in the etiology of hearing loss are modifiable, and if eliminated, might prevent or delay more than the half of the cases of hearing loss. But the mechanism by which these inequalities are generated remain unclear so far. Hearing health inequalities is an emerging research area, and we recently provided a definition saying that hearing health inequalities refer to the avoidable differences in people's hearing health across different social or population groups. Also, as audiology and hearing science are currently lacking a model for this emerging research area, my PhD provided the perfect time frame in order to construct a conceptual model, the conceptual model of hearing health inequalities. Now, I will show you this model, which depicts the modifiable determinants of hearing loss in several stages across the life course. First of all, in childhood, children born to parents from a lower socioeconomic position tend to experience more illnesses and injuries, and the antibiotic drug use may affect the hearing health, especially to children with a genetic predisposition. In turn, hearing impairment in children has consequences which may include impairment in language skills and a lower educational achievement. The lower educational status is associated with health literacy limitations, which are a common issue among people of a lower socioeconomic background. This makes sense and may explain why those in a lower socioeconomic background tend to adopt an unhealthy lifestyle with a higher body mass index, lower physical activity, a higher alcohol consumption, and alcohol intake above the low risk level guidelines, which are all risk factors for hearing loss. Also, the educational level is a predictor of educational and social inequality in later life, as relegates people to more poorly paid jobs. And these lower level manual jobs tend to be those with the higher level of occupational noise exposure, which is a major risk factor for hearing loss. The lower income may also affect the access to health services and hearing aids use due to financial barriers that may affect the help-seeking behavior for hearing difficulties. Also, the hearing loss inequalities in older age may affect the ability to continue working or to advance occupationally, so affect the retirement status. Moreover, hearing health inequalities in older adulthood affect the communication in healthcare settings and the quality of care, and by affecting the management of other chronic health conditions that are commonly comorbid with hearing loss. Moreover, hearing health inequalities accumulate. So, the lower a person's socioeconomic position during their life course is, the more the hearing health inequalities have been accumulated during the life course. And tackling socioeconomic inequalities during the life course would significantly improve the hearing health of populations. The conceptual model for hearing health inequalities could be used as a tool for prevention, identification, and management of hearing health inequalities, and for policy formulation aimed at hearing loss risk reduction. But this is a theoretical model so far, so it needs careful testing across this association. In order to do so, and to identify the role of socioeconomic and lifestyle factors, we analyzed data from the English longitudinal study of aging. This is a large representative data set with information on health, social well-being, and economic circumstances of English population aged 50 years old and above. The current sample contains up to 8 waves of data collection covering a period of 16 years. So in the Center for Primary Care, we published the first study that focuses on modifiable lifestyle factors such as high body mass index, physical inactivity, tobacco consumption, and alcohol intake above the low risk level guidelines, and the role of 4 different socioeconomic indicators: education, occupation, income, and wealth, to the objectively identified hearing loss in older adults. And what we found? Those in a lower socioeconomic position were up to 2 times more likely to have hearing loss. The adjusted odds ratio were higher for those with no qualifications versus those with a degree in higher education. for those in routine and manual occupations versus those in professional or managerial occupations, and for those in the lowest versus the highest income and wealth quantiles. Surprisingly, age and gender only explained about 15% of the variance in the likelihood of hearing loss. And socioeconomic position and lifestyle factors had an equal contribution to hearing loss as age and gender. In other words, age was not the most important risk factor for what is widely known as age-related hearing loss. These findings are supporting of a new conceptualization for hearing loss, which argues that hearing loss is not necessarily an inevitable accompaniment of aging process, but potential preventable lifestyle disease. And the term age-related hearing loss is not an inclusive term, because there are several modifiable lifestyle factors which are involved to a largest extent in the pathways of the association between socioeconomic position and hearing loss. So we thought that this term is not an inclusive term, and we thought that it's time to retire this term and find a replacement. So we proposed to the scientific community a new term, lifestyle-related hearing loss, where lifestyle refers to social practices and ways of living adopted by individuals that reflect personal, group, and socioeconomic identities. Of course, the lifestyle choices are greatly influenced by the social, economic, and environmental conditions where you live. But we must think that up to 50% of cases of hearing loss are preventable, and people have their part in making decisions in everyday life concerning the disease prevention and health promotion in order to improve or maintain their quality of life during their life course. Let's see now what's happening with the diagnosis of hearing loss in primary care. The health-seeking behavior in primary care starts with the self-diagnosis, where an individual that has hearing difficulties initiates the contact with the GP in order to seek help and a referral for investigation. However, there is a misconception here, as many people ignore that hearing loss is not only about the inability to hear sounds in terms of the intensity of a sound. Hearing loss is not only about the intensity, how loud is a sound in terms of decibels, but also is about the frequency in hertz. In an audiogram, you can see the range of average human speech that is depicted in a banana-shaped region known as the speech banana. When you have hearing loss of certain frequencies, you may not be able to detect your hearing difficulties because the frequencies that are unaffected appear pure and clear. That may lead you to the impression that your hearing is completely normal, and that may lead to a wrong self-diagnosis. And as hearing loss develops gradually, people don't see it as a dramatic health problem requiring urgent intervention, and persevere with declining hearing for approximately 10 years before they seek help and uptake a hearing aid. The patterns for self-identification of hearing difficulties in primary care were completely unknown so far, so we had the opportunity to make a comparison of the self-reported hearing data to the objective hearing data that were available in the 7th wave of ELSA, which is a representative data set, and the objective hearing data were measured by a handheld audiometric screening device. What we found? Nearly 1 in 3 people with objectively identified hearing loss did not self-identify correctly their hearing difficulties and went undetected by the self-report measures. That revealed a potential diagnostic error of hearing loss in primary care and a serious gap into the continuity of hearing health care and patient safety. In other words, up to 1/3 of older adults with hearing difficulties may remain undetected and not being referred to ear specialists or given access to hearing aids. This is highly problematic because hearing loss affects, as we said, the communication in healthcare settings, and the management of other chronic health conditions that are commonly comorbid with hearing loss. For example, we found that in all waves of ELSA, those with hearing loss had 40 to 58% higher relative risk for depressive symptoms compared to those without hearing loss. Also, hearing loss is a very important issue in geriatric medicine because it's linked not only with depression but also to cardiovascular disease, Alzheimer's and dementia, diabetes, chronic kidney disease. It's tied to threefold higher risk for falling, 32% increased hospitalization, and greater risk for mortality. You can now understand how difficult it may be for a person with chronic conditions and hearing loss to manage all these chronic health conditions. This poses greater risk for patient safety, as people with hearing loss have difficulties communication with health professionals and are frequently left unclear about their medical diagnosis and the instructions after an appointment. This is what, therefore, hard of hearing people feel when hearing people speak to them. It's hard work. It's a really hard work, and this is important not only for the patient but also for the health professional, so as to be able to do an accurate diagnosis during the communication. So it's not surprising that almost all deaf and hard of hearing people are currently dissatisfied with the way their GP communicates with them and don't have trust or confidence in their GP. And these problems with confidence and trust also are associated with medical adherence, which poses a significant risk for patient safety, especially in polypharmacy. Moreover, this has huge economical impact, as today NHS and social care services waste approximately 150 million per year by not making the primary healthcare services accessible for people with hearing loss. 14 million per year because of missed appointments, 76 million per year in extra GP visits, and 60 million per year in increased use of social care. In summary, we saw the role of socioeconomic position under diagnosis in primary care and multimorbidity and how that affects the patient's safety. This was part of my PhD project, which is funded by the NHR Magistrate Biomedical Research Center, and I am honored to work under the supervision of Dr. Maria Panagiotti, Professor Evan Kotopantelis, and Professor Darren Ashcroft. The decade of healthy aging has just started, and the WHO has recently highlighted the need for community-based, sustainable and inclusive strategies for hearing and hearing care integrated within the primary healthcare system. The vision is for a world in which no person experiences hearing loss due to preventable causes, and those with unavoidable hearing loss can achieve their full potential through appropriate interventions, education and empowerment. The role of primary care is important, and is more important than ever. And we are very proud that we are hosting the first event dedicated in hearing loss research in primary care. That means that we are at the right place, at the right time, and being ready. Thank you very much. To welcome Dr. Angie Henrich, which will present a talk, Effective Communication as a Fundamental Aspect of Active Aging and Well-Being. Angie is a senior lecturer in the Magister Center for Audiology and Deafness, and also is my academic advisor during my studies.
Okay, thank you. Do I need?
Yeah.
All right. I was going to say, can everyone hear me? Actually, does that work? So much. Right. Okay. Excellent. Okay, hello everyone. I'm going to talk to you about communication in general today, and in particular we're going to look at it through the lens of hearing loss and aging. Because we know that successful communication is vital for well-being, and difficulties in following conversations, particularly in noise, will prompt withdrawal from social situations, will lead to a less active and satisfying lifestyle, and an increased risk of loneliness. We also know that difficulty following conversations, particularly in noise, is one of the most common complaints that older listeners have. So it's really quite important to think about this and what we can do about this. What I'm going to do is to consider all the, communication is a very multifaceted concept, and so we're going to consider all of its different facets within the framework of the ICF, and I was actually really pleased to see that Dalia already put that up, the schema for that. So the ICF is the International Classification of Functioning Disability and Health that was originally proposed by the WHO in 2001, and that's a very sort of general framework that basically sees a particular level of functioning of a person not only as based on its body functions and structure, so physiology and anatomy, but also what sort of activities they engage in, what sort of participation level they have, what sort of activities and environments they participate in. But also these three things can be modified by environmental factors and personal factors. And at the very end of my talk, I will talk a little bit about this, what we can do to make communication easier, essentially. This general framework was adapted to communication and hearing a few years ago, and so basically the health condition is communication, and we're going to look at body function as they pertain to various hearing functions and to cognition as well. We are going to consider activity as in various different ways of speech understanding, and how they tie in with various social interactions and social situations and participation. And as I said, at the end, I also want to consider certain environmental factors, such as background noise, reverberation, talker characteristics, but also characteristics within the listener, within the receiver. So whether they're native or non-native speakers, for instance, what their self-efficacy is, that sort of stuff. So that's sort of the outline for the talk I'm going to give, and we are going to start with considering a number of different body functions, as they're called within the ICF, that are related to hearing and communication. Much of what I'm saying comes from a paper that we published a few years ago. So I'm aware that I'm going to give you a lot of different information. If you want to read up on any of it or get more information, then I will direct you to this particular paper, and I'm going to put it up at the end of the talk as well. The body functions I want to talk about in particular are various functions of hearing, and then things that are connected to cognition, such as attention, memory, intellectual function, and language. So again, as Dalia has already mentioned before, there are 12 million people in the UK that have a hearing loss, and that is projected to increase to 15.6 million in the next 15 years. The vast majority of those have a mild to moderate hearing loss, and 40% of them are actually younger than 65. That of course means that the majority is actually over 65. However, it's worth keeping in mind that actually 40% of people 50 years and older have a clinically significant hearing loss, and once you reach the age of 70, then 70% of people have a clinically significant hearing loss. So that's basically the majority of people you will deal with. I don't know how many of you are connected to audiology here or not, but I just thought I would very quickly go over the audio and what it actually shows, so that you understand basically. So this is like one of the most fundamental hearing tests you will get when you go to the, probably not the GP, but the hearing clinic to get your hearing tested. And essentially what you see here are a lot of different frequencies. So you start with low, so these are like low tone frequencies up to very high frequencies. And here you see the level, the sound level that a tone of that frequency needs in order to be heard. And all of the measurements that are done are basically done in comparison to to young normal hearing listeners. So if you're here as well as the average normal hearing listener, you should score something to 0 on all of these frequencies. However, if you need more, like a higher level essentially, than a young person in order to hear that sound, then you go down that scale. So basically down the scale is a louder tone, it's a more intense tone. So what you will see if you're a young person and you have an average hearing, you should have something that's very similar to 0 across all of the frequencies. Normally you test up to 8 kilohertz. However, as you get older, your audiogram very slowly starts changing, and it will change in something like this manner. And what you will see is that the high frequencies in particular are the ones where you need basically a higher intensity sound the earliest in order to hear it. Whereas as you get older, so these are like higher and basically louder and louder sounds. But even for lower frequencies, so lower frequency sounds, you need basically more intensity to hear them. But the higher sounds are basically, you need most, basically the louder sounds for the highest frequencies and just a little bit for the lower frequencies. If you now remember back to the speech banana that Dalia just showed, basically what that looked like was something like this. So that essentially means as you get older, there's a certain set of speech sounds that are most likely to fall under, like below, the level of what you can hear. So the level of what you can hear is this. If the speech sounds fall below that, then you can't hear those speech sounds anymore. And that's where the problems come in. There's no question that loss in hearing sensitivity is very important and actually does explain a large part of communication problems. And this has been known for a very long time. However, it's also quite well known that actually hearing sensitivity, regardless of how important it is, it's probably not the whole story. And there are lots of other sort of bits that are also important, and I will try to highlight them during the rest of the talk. One of the bits that are also important, that are not hearing sensitivity, is that actually there are other functions in hearing that are also important and that do change. So for instance, as you get older, normally temporal sensitivity decreases. Temporal sensitivity is basically like how small pauses can you hear. Spatial sensitivity, how well can you orient a sound in space. Dynamic gain, how well can you deal with a sound that changes in level quickly. And all of these things get worse as you get older. There's no question that all of these are related or are basically affect speech and noise perception and ultimately communication as well. However, exactly how they affect that is not very well known. So the other thing that's important to keep in mind is that while hearing function is undoubtedly very important, it's again also not the only factor that is important. So, for instance, there are listeners who have very similar listening profiles or very similar hearing profiles, yet the level at which they can understand speech and noise and communicate is very different. Or conversely, people have very different hearing profiles can be very similar in the way that they communicate. So if it's not all about hearing, then the question is, what is it about? What else is important? And the one thing I would like to talk about next is cognition, so basically your ability to think. There are a lot of different aspects of cognition, and I will only be talking about those that are connected to speech and noise perception. And the first aspect I want to talk about is attention. And attention essentially is about knowing where the communication takes place, being able to segregate the foreground or the target or what you're interested in from a background, to be able to detect the important information, and also to switch between conversation partners. So there are lots of different frameworks to talk about attention as well, and we're going to go with Peters and Posner's, because there are 4 different aspects of attention that are quite well suited to looking at them in the context of communication. And they are alertness, sustained attention, spatial orientation, expectation, and reorientation. And then what we can do is basically run studies that particularly look at each one of these aspects and compare young and old adults on them while controlling everything else. And when you do that, you find out that actually old adults are quite good in spatial orientation. They are a bit slower, they find it a bit harder to they take a bit more time to orient a sound in space, but they can do it, and they will be as accurate as young people once they have done that. What they find more difficult is if they then have to disengage from that one location and have to relocate to another location. They find that much harder. And you can see how that may relate to communication if there are a number of people in the room and you're trying to change communication partners from one person to the other. That is much harder as you get older to do. Another aspect of cognition or attention actually that's important for communication is to be able to follow lots of different streams of attention. So often there's more than one stream of information that you want to follow, and to basically follow all of them and then decide what is important and what isn't. And the two sort of aspects of attention that are important for that is divided attention. So follow all the different types of basically all the people who are talking in the room, and you want to, you're standing with one person having a conversation with them, but actually you're also listening into some other conversation. Is there anything important that I need to keep track of? So keeping track of all of that at the same time and dividing attention between different speech streams, for instance, and then deciding, okay, I want to stick with the person that I'm talking to at the moment, and just basically trying to ignore whatever else is going on. And when these functions are basically, again, tested under well-controlled circumstances, tested in the lab, and younger and older adults are tested, then what comes out is that older adults find it much harder to divide attention, and they also find it much harder to inhibit the irrelevant information. It doesn't matter, they know it's irrelevant information, that's not the point. It's just much harder to not listen to it, essentially. And again, it's quite clear to see how this can tie in with successful speech perception and communication. There's a lot of discussion of why that is and why older adults find that so difficult. And one very popular sort of explanation is that we have a finite pool of resources. So something like mental energy, how much power we have to spend energy we have to spend on all of this, and that is finite, and presumably, or maybe, that pool is even smaller in young and old adults than young adults. So basically they just have less mental energy to spend, and because all of these things are very energy consuming, if you have less energy, it's not that surprising that you're not as good at these. So that's one explanation. The problem with this explanation is that it's really difficult to actually measure that pool of resources. That's essentially a theoretical concept, and it's really, really difficult to know what that actually means in terms of measurement. The other related explanation of why that happens with aging is that basically older adults may just listen differently, essentially. And they might have to spend their energy a lot more to make up for the hearing loss that they have, and actually to perceive the words, and then there's just not very much left to do anything afterwards. And that is the reason why functions that come after the perception, before you can divide attention, you have to be able to actually hear what is being said in all of these speech streams. And maybe by the time that they have worked so hard to actually figure out what is being said in all of these speech streams, they're pretty much exhausted and can't do the divided attention anymore, or they just can't inhibit the irrelevant information anymore. So that's another explanation for why older adults are poorer at these sort of functions. Before I go on with that, I just very quickly want to talk a little bit more about sort of basic cognitive functions that also change and that are important for speech perception and cognition and communication. Another one that is important is memory. And basically, memory is when you have to retrieve information that was heard over the course of the conversation. And the sort of conventional wisdom is, of course, as you get older, memory gets worse. That's actually not quite true in that entirety. What does get worse is self-initiated retrieval, so essentially where people are being presented with information and 10 minutes later they're being told, okay, and now tell me what you remember. And there's no structure to it, and there's no other cues to it, and they're just basically left to their own devices. And in that case, old adults tend to not do very well. However, when the questions is asked a little bit differently, and previously presented information is presented again, and then people are asked, can you tell me which of the information you've heard before, then old adults do just as well as young people. So clearly, the information is still there, and they can remember it. It was just really difficult to sort of come up with it themselves. But when they had help coming up with it, they did just as well as the young people. So that's important to keep in mind. Intellectual function, also important for communication. And here I want to make the distinction between fluid and crystallized intelligence, where fluid intelligence is basically the ability to perceive relationships independent of practice and instruction. So that's the classic tasks where they're like novel tasks where you have to find the rules, or where you have to work with novel information that has nothing to do with practice at all in any sort of way. And one type of function that sort of is related to that, and that is important for speech perception, is working memory. In working memory, what people normally do is they hear information that they have to keep in mind, and often they also have to manipulate the information in some sort of way. I don't know, like for instance, when that is tested in the lab, people would hear a number of numbers, and they would have to reverse the numbers in their mind before they sort of repeat it back. So that has a memory aspect, and it has a manipulation aspect, that sort of thing. Crystallized intelligence is essentially knowledge that has accumulated over time, and tends to be vocabulary and word knowledge, that sort of thing. Now, interestingly, if we look at developmental curves over the lifespan, what we see is that for fluid intelligence, so anything to do with having to process new information that has nothing to do with anything previously learned, but new information, that tends to go down pretty steeply over time. So basically, this is like a large cross-sectional study where they tested people who were in their 20s, 30s, 40s, up to their 80s, and they were all tested on the same kind of task. And the result is basically, or the performance of people is here, and this is their ages. And what you can see is on the same kind of task, people get worse and worse and worse as they get older. And that is a very common trajectory for fluid intelligence tasks. There's nothing to worry about. This is just how it looks like. The one thing I want to draw your attention to, though, is that there are some tasks where as people get older, they actually tend to do better. And that is vocabulary, as we said, and that is verbal knowledge, so that's basically word knowledge. Okay, those are two things where old adults do perfectly fine. Okay, so you could basically, maybe we could postulate here that if you were an intelligent listener, shouldn't you try to adjust your listening strategies to use the cognitive abilities where you're good at? Because this is most likely to be successful. And I will show you some data that's actually exactly what happens with older adults. Okay, so but for now, what I want to say is that some cognitive decline, particularly in these fluid intelligence domains is perfectly normal. However, sometimes you get more decline than what would be considered normal, and that can venture into the abnormal. And one way to sort of talk about this is under the umbrella of dementia. How this relates to hearing loss is that hearing impairment, particularly untreated hearing impairment, may increase the risk of incidence dementia. And just to sort of drive that home, that point a bit more, is that a few years ago there was a paper that made a really big splash that tried to calculate the risk factors for dementia, and essentially they divided them up into non-modifiable risk factors, so there's not much you can do about them, and modifiable risk factors. And the modifiable risk factors for dementia make up about 35%, and out of those modifiable risk factors, hearing loss is the biggest one. So treating hearing loss, diagnosing hearing loss, and treating hearing loss is very important to basically modify the risk factors for incidence dementia. The only thing I want to say to language function is that we're all aware that we are living in a more and more multicultural environment, and more people speak the language that we are communicating in as an additional or second language. And that is always a bit more effortful and harder under any conditions, but that's particularly true in complex listening situations such as background noise. So that is really important to keep in mind when you are communicating with people who speak English as an additional language. And again, I'll come back to it, what it is that you can do to sort of make it easier. Okay, so these are basically very basic body functions that that are there for lots of for lots of different health conditions, but that are important for communication as well. Now, the question is, how do these body functions in hearing and cognition combine to affect speech understanding and social interaction? So we're going to look at that now. And we're going to look in particular at how hearing loss combines with attention and memory, with attention and intellectuality, with mobility, and with balance. I've already touched on the idea of a pool of cognitive resources or mental energy that is restricted in everyone, but maybe more restricted in older adults. This is the basically original drawing from the original publication on this. What I want you to focus on is, so this is basically the restricted pool of resources. And because it is restricted, there has to be some sort of allocation policy of how do you spend that restricted resource. Like where do you put your energy, essentially? And there are a number of different activities that it can be spent on. And one of the sort of important ideas in the field of age-related changes in speech and noise perception is that older adults, because they have a hearing impairment, have to allocate more of their resources to perception. They basically, because they can't hear so well, they have to figure out what the words are that they can't hear, and they have to compensate that in some sort of way, and they just have to work harder. And the problem is, because they're already spending all their energy in trying to figure out what's actually that is being said, there's not a whole lot left for post-perception processes, and those post-perception processes are things like integration of information, comprehension, and memory. And then that looks like a cognitive decline, even though the reason it's there is because they just don't have the energy to do this. And actually, there's quite good evidence to support this line of to support this, because when perceptual differences between age groups are minimized, so essentially when it's being made easier for old people to listen, then they're just as good at integration and comprehension and memory. Because they didn't have to work so hard to figure out what's actually being said. The problem with this line of research is that in the real world, of course, we can't differentially adjust the listening world. It's one environment, and everyone has to function in the same environment, and that environment is just differentially harder to function in for older adults. But if there's any way we can figure out how to do that, that would be fantastic, because that may get rid of some of the communication difficulties that we currently see. The other point I would like to make is that, as we have seen, that listening to speech noise requires a large range of perceptual and cognitive abilities, and people who do better and who have better perceptual abilities and better cognitive abilities will do better in speech to noise perception. So, as we've said before, we know that that fluid intelligence decreases with age, crystallized doesn't. So the smart older listener would try to use listening strategies that build on what they're good at, which is the crystallized intelligence. And that's exactly what we see in our data as well. So basically, young and old adults just listen differently. And older adults tend to compensate their perceptual difficulties using crystallized intelligence. They use what they know about language. What sort of word do they think should be used in this particular context if they get the context right? And they're actually really good at this. Whereas young adults use completely different strategies and use working memory and sort of work it out in a very different way. So it's basically worth keeping in mind that even when young and old adults arrive at the same comprehension level, they probably got there in very different ways. Okay, now I want to move on to something completely different now, which is walking and mobility. And some of you may think, what does that have to do with hearing? And then I will tell you that mobility actually has a very close relationship with hearing. And so people who have poor hearing also tend to have poor postural balance. They tend to have lower limb performance, slower walking speed, more perceived walking difficulties, and actually, hearing impairment can be used to predict new incidences of walking difficulties and falls. That may make you think, how can this possibly be related one to the other? And those of you who have a background in audiology will probably then say, wait a minute, that is because both the hearing and the balance is actually functions are actually located in the same organ, which is the inner ear, and they both depend on the same battery or power function to basically work, which is the stria vascularis, which powers both hearing and vestibular function. And we know that the stria vascularis changes with age and gets weaker and weaker. So both the powering for hearing and for vestibular function gets less. And so they both concomitantly may change both of these functions because they depend on the same structure. And you will not be surprised to then hear that if you have a joint impairment in hearing and balance, which is likely, there are lots of participation restrictions that you have. So, and that may have a lot of reasons. So people who have a hearing loss have poorer spatial orientation, and because they have poorer balance, that leads to more falling, and that may lead to them withdrawing from social participation, not going out as much anymore because they're worried something will happen or they can't orient themselves very well. What has also been shown is that the risk of falling, because they're worried about falling, leads to more attention being paid, more resources being allocated to balance, which essentially then means that that is unavailable for communication. And there's actually good evidence to show from the lab that when older adults trying to navigate an obstacle course, they can't hold down a conversation and they can't remember anything because they are paying all of their attention to trying to not fall over. So, and all of these things, of course, make it much harder to participate, to go out and to participate and to go into the social environment. That means there's less participation in group activities, there's less time spent outside the home because it's A, too risky, and B, they're not getting as much out of it. They have a higher risk of withdrawal from leisure activities, and basically more inactivity, and that ultimately leads to higher risk of loneliness and to social isolation. So, what can we do about this? There are a number of factors within the environment that can basically be adjusted to try and sort of shift the balance a little bit of all of the sort of complex relationships that I've talked about. And there are a number of things that we can think about. So one is technology, such as hearing aids, wearables, so anything that can help to hear will help to redistribute the resources to the post-perception and to help the communication. Quality of the sound. You can think, for instance, about architectural guidelines. So how are public buildings, for instance, built? Can we make sure that they are not as reverberant and not as echoey, and that it's easy to listen to them, that they have sound-absorbing carpets, just to make the listening as easy as possible. Same with the background sources. Can we make sure that it's not, we don't have reverberant sort of walls, but that it's basically like here, nice and carpeted. Talker characteristics. Sometimes you can't do anything about it. So again, if talkers speak with a heavy accent, whatever, it might be a native accent, doesn't matter, but with an accent you just have to deal with it. However, there are talker characteristics you can do something about, and actually the BBC in Salford is quite interested in some of the research that we are doing in order to know how should they mix sound for TV productions, for instance, to make it as accessible for hearing impaired listeners as possible. What is important and what isn't in order to improve hearing. So again, in order to help communication and in order to help post-perception processes. The one thing I do want to talk about just on my very last slide, because I think it doesn't get talked about very often, are individual and societal attitudes. And just want to talk, basically, there is a large amount of ageism in our society, and that is true for all, at least Western societies, so I don't think the UK is special in any sort of way. But basically that means that older adults get stereotyped as incompetent across several mental abilities. And that can then lead to misattributions. So, for instance, there's a really famous experiment where they tested young and old adults, and for older adults, it was a vision experiment. For older adults, they made the font less legible, and as a result, older adults didn't do very well. It had nothing to do with their cognition; it just had to do with the fact that they couldn't read the font very well. Both the older adults as well as the young people all attributed that to cognitive decline. And something similar is very likely probably going on with hearing as well, simply because older adults can't hear very well and have to spend so much energy in figuring out actually what is being heard that they can't do the post-perception stages very well, and that is being misinterpreted then as cognitive decline. And of course, that's even worse in as a sort of self-fulfilling prophecy, because when people are aware that that is happening, then they are performing to that lower standard, and it will get even worse. So it's quite important to be aware of it, and ideally not try to project that. Okay, I think that's all I have to say, and basically I hope I convinced you that communication is a very sort of wide-ranging, multifaceted concept that is directly and indirectly linked to hearing in many different ways, and only if we look at it in its entirety can we actually hope to improve speech perception and communication for everyone. Okay.
Thank you very much, Anzi. We just have maybe 2-3 minutes for questions. Do we have any questions?
Thank you. I do think I'm the oldest person here, so I qualify for the first question. I've been hanging around the health service in Manchester for about 30 years. Nobody's ever mentioned a hearing clinic to me before. I didn't even know there were such things. And even though I'm getting a bit old, nobody's ever suggested to me that I should have my hearing tested. Would it be a good idea if people have their hearing tested? How am I supposed to know that my hearing has deteriorated?
At the moment, and Dalia sort of mentioned, what you need is you need to suggest it to your GP, who may or may not refer you to audiology services. I think there is some suggestion of having a sort of screening service online where people can self-assess, and then I think the problem with that then also is there needs to be a follow-up, because what will probably happen is that a lot more people will realize that they have a hearing loss, and they actually have, that they should actually get a hearing aid, and they are eligible for, with a certain amount of hearing loss, they are eligible for a hearing aid within the NHS. However, all of that would have to be managed within the hearing services somehow, and it's a little bit like, opening a can of worms. And so at the moment, that is being put back on the patient by having to take the initiative. I think that's, I can see why the NHS does it. I don't think that's quite right. And I think you're absolutely right that there should be more widespread hearing testing. I think the other thing also is, to be honest, there are quite a few people who have hearing aids and don't use them. So in order to use them, there are quite a few people who, if you test them audiometrically, they have a hearing loss, and they swear they don't. And I think that's entirely fine. And maybe they can, but there has to be that sort of buy-in as well from the patient. And so just having the screening online, I don't know, is maybe not enough.
I was just going to add that the Action on Hearing Loss website has got a self-screen, so you can go on there and test.
Any question? Any more question? If not, we are ready to have a short break for coffee and biscuits, and come back in 10-15 minutes to continue our session. Thank you.
Hello everyone. Hi there, hello everyone. Hello everyone. So it's a pleasure really to have. Hello everyone. Okay, thank you so much for staying over. So it's a pleasure to have Dr. Helen Henshaw and Jean Stroh to join us for the next 45 interesting talk for 45 minutes. Thank you.
I'm just going to take my watch off to make sure I keep track of the time, so you want to listen to Jean's time. So we're going to share this talk. So thank you for the introduction, and thanks Dalia for organising this really exciting event. It's not something that I've been involved in before, but it's really nice to see how you've brought everything together. And I sat there listening to you talk, and I can agree with absolutely everything you said. So definitely didn't think of myself as a primary care researcher. Clearly I am. So my name's Helen Henshaw. I've got a background in psychology by training, and I have worked for the NIHR in its various forms for about 10 years now. So I started off at the Biomedical Research Unit in Hearing in Nottingham, now the Biomedical Research Centre, and most recently I'm an NIHR fellowship holder at the BRC in Nottingham. As I was sitting there earlier, I realised that Antje and I have worked together for 8 years now, and we present each other's work all the time, and this is the first time I've ever sat in one of her talks, and possibly vice versa. So even when you work with people, you probably don't know what they're doing. So I'm going to talk to you today about one of my favourite projects that I've ever been involved in. Not only because it's where Jean and I met, so Jean is a patient representative that worked really closely on the project with us, but also because this project allowed us to bring together everybody who has either lived or daily experience of mild to moderate hearing loss, to talk about our frustrations in what we don't know in terms of research answers, and also opportunities for what we could know in the future if the research was actually directed correctly. So why is this important? Well, the patient voice isn't always heard, and that's a real problem as researchers that we need to address. So on Friday I came across this tweet by Emily McBride. She's a health psychologist, and she picked up on an article that was commissioned by the BMJ, but disappointingly didn't have health psychology input, despite it being completely about health beliefs and why that should be at the top of our communication list when we think about health interactions. So patients will come along to any kind of medical appointment with a predefined set of beliefs about their health condition. And it's really important that we have an insight into that. They will be guided by a multitude of factors that they've accumulated over their life. But the point that Emily picks out here, do not want to do that. Do we have a pointer? Doesn't matter. The point she picks out is that doctors frequently fail to understand patients' health beliefs, dismissing those that are not congruent with their own. In the centre. Brilliant. Sits up here. Thank you. So that made me think, well, what does this mean for something that's hidden, like a condition such as hearing loss? And we do have a real issue, because what happens in that interaction is key, if that interaction happens at all. So we've heard this a couple of times already this morning. People delay seeking help for their hearing difficulties for up to 10 years. There is some new data that suggests that might be coming down slightly to around about 7 to 10 years, but this is a really, really long time, and there are many reasons for that. Least of all because people have to self-diagnose, and that's not always clear. But one of the other issues we have is the dismissal of hearing loss as a normal part of ageing, either by significant others or by healthcare professionals, can be a real barrier to seeking help. And quite worryingly, between 30 and 45% of people presenting at their GP with hearing difficulties do not receive an onward referral for hearing assessment. They get sent home. And that's a big, big barrier. But things are getting better. In 2015, the government in the UK generated the Action Plan on Hearing Loss, which guided quite a number of issues and thought processes to make sure that all services started to consider hearing health. In 2018, we had the publication of the NICE guidance on assessment and management of hearing loss in adults. And this recommends that audiological assessment is offered to all adults who present for the first time with hearing difficulties, or for whom the clinician suspects has hearing difficulties. Somebody mentioned earlier about GP training. So for the first time, the curriculum has been updated to include specific information about hearing loss this year. GPs are expected to be able to communicate effectively with people with hearing loss, and they are encouraged to promote the benefits of early intervention to make sure those who need hearing aids get the most out of them. And well, we're here at a World Health Organisation registered event. We do have a report coming out later this year which should look at all people receiving intervention on hearing across all services at all levels. So this is something that's going to be pushed really heavily towards the end of this year. So why is research in hearing loss so important? Well, there is a growing need for this. Sensorineural hearing loss, which we heard earlier, accounts for the majority of hearing loss in the UK. So 92% of all cases of hearing loss are sensorineural mild to moderate hearing loss. It's a progressive condition affecting our most relied upon indicator of quality of life, that's social interaction. When we walked in earlier, I don't know if you all registered the YouTube video that Dalia put up, but it was a song being played, and then all of a sudden it went quiet, and it was showing you that it was indicative of profound hearing loss. If you had all of your sound taken away tomorrow, how would you cope? Not very well, I guess. We've heard many times today that by 2035, hearing loss will affect 1 in 5 of the UK population. And something that was highlighted back in 2013, unfortunately still holds true today, in that hearing loss continues to be an area in which there is low and highly variable take-up of available interventions, typically hearing aids, and very little systematic data for outcomes for patients. So this needs to change. One of the big issues we have across the board in research is that up to 85% of funds invested have no direct value for patient need. And the mismatch between what research agendas push, what people want to fund in terms of the research agenda, and what academics want to achieve, can often be reduced just by involving patients from the outset. We've known this for over a decade, but it's still not always done. The James Lind Alliance, the priority setting partnerships that they've projected, they aim to put those with lived and daily experience of a given condition on an equal footing with researchers to raise awareness of research that will make a difference. So I'm going to talk to you about our PSP in mild to moderate hearing loss for adults. And then we're going to kind of do a double act, aren't we, Keane, whereby you're going to come in and tell us about what else you've done in the research world. So our priority setting partnership was established in 2014, and we joined together with Linda Sharkey at Hearing Link. So Hearing Link is the UK charity for people with hearing loss and their families, so it's really important that families were involved from the outset. And Linda introduced us to Jean Strauss and Robin Wicks, who were active volunteers for Hearing Link, for Action on Hearing Loss, and for many other causes. And we began the quite long and drawn out process of thinking about, okay, so if we're going to set up a priority setting partnership, who are our key stakeholders, and how can we make sure that we have the widest representation possible to make sure that patients, their family and friends and clinicians are properly acknowledged in this process and bought in right from the start. So we sat together in a room and we came up with not only a list of partners that we wanted to work closely with, but also some ground rules for how that priority setting partnership would work. So if we were going to involve people with hearing loss, we needed to make sure that we had adequate communication support, ground rules for making sure that people could understand and be fully engaged within the process, and making sure that we didn't have teleconferences too often, for example, because that just rules people out. We got some great representation from some of the key professional bodies and patient bodies within the UK. And what was really nice is that the volunteers we got to come forward from those charities, a lot of them actually had lived experience of hearing loss themselves too, so they wore multiple hats. So the PSP process is something that's guided pretty closely by the James Lind Alliance, and it has 4 key stages. And there are really clear guidance that you can find online. So the JLA guidebook guides you through this process. But in addition to that, the James Lind they let you pay for an independent advisor who will come and govern the whole process alongside you. Now, if anybody is thinking about taking one of these up, it will take you around about 12 to 18 months to complete and will cost around about £30,000. So it's kind of one of those things where you need quite a lot of admin support. Now, the big work is not in just asking people what the questions are that they want to submit. The big work is in dealing with the data that comes back. So I'm just going to go through the process really quickly for you. So the first thing to do is to survey as widely as possible patients, their family and friends, clinicians, on what they don't know about mild to moderate hearing loss in adults that they would like future research to address. Now, the scope of the James Lind Alliance has typically in the past been on treatments. So what is it about the treatment of mild to moderate hearing loss that you don't know? What we decided very early on with our PSP was to have a look at a much wider scope than that. So we were looking at diagnosis, prevention and treatment. So what are all the unanswered questions in those 3 areas that we could address by future research? And what should we address? What do people need? The next big step in here is the data management. So all of the individual questions that come out of the process, they need collating, they need chunking together. So one question could be asked in 50 different ways, and we need to come up with the indicative question that people are trying to ask when they submit those. And then we need to check that it's not already been answered. So in terms of how the James Lind Alliance believe you can make this decision is if there is an up-to-date systematic review, which means that it's been done within the last 2 years, that has a definitive answer. And you can imagine in the hearing loss we had 0 of those. Next, once we have the indicative questions, we had 87. They go out to an interim prioritisation where people rank which ones they think are the most important. And then we come together in a final consensus workshop to develop the top 10. And this is more of a marketing exercise by the James Lind Alliance. You put the top 10 out there because they are the most important questions as ranked by patients and clinicians who know what the condition is. But the full list are really interesting. And the NIHR, for example, will fund anything on that list if they think it's worthy of funding. So this is what our first survey looked like, survey round 1. We did it both online and postal to make sure that it could reach our target audience as widely as possible. And our priority setting partnership set up a really comprehensive communication plan. So all of the key stakeholders linked in with their networks to make sure that we could get this survey out as widely as possible. And it was a very open question. What questions about the prevention, diagnosis or treatment of mild to moderate hearing loss in adults would you like to see answered by research? We got 1,147 individual questions submitted by 461 respondents. So people submitted multiple questions. You can see 4 boxes here. They could add, they could continue as long as they wanted, and some people did. We have a great representation of people with hearing loss. So 68% were people with lived experience of mild to moderate hearing loss submitting their questions. 20% friends and relatives and 19% healthcare professionals. What's missing there is other, so they fall into researchers or other categories. And then a poor research assistant called Laura Daly had the arduous task of combining all of the submissions into something that made coherent sense. So you can see here 3 individual submissions that we received that were all about, can new technologies replace hearing aids? We didn't come up with just this sentence, we actually designed it in a PICO format, which for the researchers of you out there, participants, intervention, control or comparator, and outcome, so that we could then go back to the literature and decide whether those questions had already been answered. We had 87 indicative questions in total from those 1,147 responses, and they fell into these categories. So 56 of the questions were on treatments, as you would think, but 14 and 17 for diagnosis and prevention. So we did also get quite a nice representation across those other 2 categories, which I think will play into today. And the interim prioritisation survey, so round 2, 486 individual respondents, so very similar to round 1. It was disseminated across the same network, so you would think so, but a higher proportion of people with hearing loss. Once the questions were out there were more people that were willing to then go and rank them, which I thought was quite interesting. And in our final workshop, we had an excellent representation of those 3 key stakeholder groups, so patients, their family and friends, and their clinicians. Some people wearing multiple hats again. Nice picture of Jean, central here, taking part in the hard work of the prioritisation process. So in the final workshop we used something called nominal group technique, which separates people out into groups. They have discussions on their own, brings them all back together, and it's designed to generate consensus quite quickly. And luckily for us and for our purse, this was managed by the JLA, so they had 4 advisors that day to manage the process really nicely. And you can see again we had communication support to make sure that everybody was involved. So the output of that was that we had a summary article, commentary in the Lancet to highlight the top 10 research priorities. And if you're, I thought that was my next slide, so I moved them around. So we highlighted them in the Lancet, but the impact went much further than that. So one of the key things about the JLA process is that you continually go. It's there forever. It's like an evolving process. So I am continually on the lookout for impacts that this JLA has had and continues to have as it evolves. So it's been published for 5 years now. Where are we? We've been involved in an internal evaluation of the JLA. So they conducted an evaluation of the whole process itself, what works, what doesn't work, and that's recently been published. So we were central to that. We've been mentioned in 2 Department of Health reports. One, an NHR Horizon scanning report, which was looking at new technologies for hearing loss. 3 systematic reviews have been published, 1 ongoing, and 2 funded research projects already. And if you want to keep up to date with the impact, it's available on this webpage, but for all PSPs, so you can go in there and see actually what's been done since they've been published. So if you're interested, this is the top 10, which, as I say, is more of a marketing exercise than anything, but this is what people have ranked as the top 10 questions for future research. One of the things that really struck us was that there was a lot of device questions in here. We know there's a lot of treatment questions, but patients and clinicians know about hearing aids. Hearing aids are currently the number 1 management strategy for mild to moderate hearing loss in adults, and that comes through on here. But one of the things that Antje picked up on is low uptake of hearing aids and low use once they're actually issued out. And this was priority number 4 from the JLA. And the NIHR will fund this research. So I've got a 3-year fellowship to look specifically at this from a health behaviour perspective now. So I just want to, before I pass over to Jean, I just want to say thank you to all the people who were involved in the process. These things don't happen lightly. It's something that's, it really does bring you into the community in terms of getting to know people, but it requires a lot of input, a lot of commitment, and all of these people, I won't name them individually, I'll be here and take over Jean's spot for too long, but they're all central to the completion and the success of the JLA. I'm going to pass over to Jean to tell you the patient perspective.
Thank you. May I ask a question?
Of course you can. We have got time at the end, but
just a quick question.
Yeah, of course you can.
Is there any way to keep track which of these 87 questions have already answered what is the evidence so far, in order to monitor the evidence?
Yeah, that's one of the things, the tasks that we did within the JLA. So we looked at the evidence. I have all of the searches in a folder, but they haven't been uploaded to the JLA website because we ran out of funds for our research assistant. It's one of those jobs that I keep saying I'll do that while I'm on maternity leave, and it didn't happen. So there was no evidence. There were hardly any guidelines at the time that this was published. But what you have a difficulty in is that the way that the question is formulated may have been answered in a slightly different way. So actually having that continuity between the two is difficult to monitor. The easiest way we can do it is to look who's referenced us. So we do that quite often, to do a search to see anybody new who's referenced the JLA, then we know that they're obviously trying to address something. And then sometimes people will just get in touch directly and say, look, we're working on this. So that's really helpful. But it's one of those things, monitoring the impact is very difficult. And it came out of the JLA report that they did internally, which was, how do we do this? And are there good examples out there of doing it well? And those were kind of the processes that they go through. But yeah, it's tricky. It's tricky to keep track of the field.
Is this a microphone?
It is. Fabulous.
And this?
So that's just attached. You can leave that on the table unless you've got a lovely pocket, which I don't have.
I have a lot to tell you about, and I want to introduce myself. But first of all, I want to do an experiment that comes about from what Anja said. So you were saying that I know there's something called cognitive overload, where when you have hearing loss, which I have big time, you have trouble processing. Too much is going on. So I'm going to ask somebody who speaks with a foreign accent to comment about today, just to make one sentence or two, and then I'm going to see how I heard you, and preferably somebody towards the back. I have a microphone here, but I'm not going to be using it now. Okay? So any volunteer? Okay?
So you wanted to say something now?
Yeah, say something. No.
Hello, we are here today in the business school. We are attending the Here For You workshop. It's been a very nice and interesting day so far.
Okay, there was something about a workshop. I heard the It's been a very interesting day so far. When that came through completely, I knew what was being said. I kind of missed the beginning, and that held me back because I was trying to get the consonants and the consonants into words, and the words into sentences along with the intonation, and then from that to make sense of it all, and then to speak to you, to give you that. So that is a lot going on for me with hearing loss. So I think the experiment proved your point, didn't it? Yeah. Okay, so first a little bit about me. Everybody comes up to me after I give a talk and says, "Where are you from?" So I'm from Minnesota. Who's been there? One person, right. I was a teacher of children with behavior and mental health problems. I have 2 daughters. I'm going to start with the sad bit, and the sad bit is the negative bit. And you have to have some of that so that you're motivated for the value of what we're doing here. So I had, in the middle of one night in about 2003, I woke up sick thinking I was having a heart attack and was dizzy and throwing up and didn't know what should happen. And eventually a friend came and took me and the daughter who was with me to the hospital, and the hospital said, "You'll be fine, just go home." My hearing was different, and there was a different sound in my ears. I didn't know any of the terms that I now could just throw at you really easily. So it carried on. So I went to the GP, and the GP said, "Oh yeah, everybody has that. You just got a bit of labyrinthitis. You go home, you'll be fine." Well, if he had known, if the emergency department had known what they provisionally issued in the NICE guidelines last year, that if somebody has a sudden drop in their hearing, give them steroids. We don't know if it will work, but at least try. Then maybe I wouldn't be here today. We're talking about, that is a mistake of primary care, isn't it? But there's the mistakes in diagnosis. This is the thing that recently happened to me in primary care. It's communication. I had a blood test at my GP, and I was told that a week later I could call in and get results. Well, I was free. Now I know that my phone streams to my hearing aids, and that's wonderful. But I can't know that it will work for sure. And I thought, look, the nurse is going to be there. I'm going to go in, and the nurse will see me. So I went to reception, and I said, I'm here, so I thought I could speak to the nurse. And the receptionist said, no, you can't. You have to phone in. And I said, well, I thought I'd be more comfortable with my hearing loss if I could speak to her. And she said, well, no, everybody here is trained. And look, you've got your phone here. You use it the way you use it. And I said, what? So if I went outside and phoned, then I would be allowed to speak to her, but I can't speak to her in person. And she said, that's right. In the end, all I got was a printout and no conversation. And even as I tell you now, it's hard not to be angry, you know? And that's a thing that none of you has had to refer to here, which is the disappointment that comes with the hearing loss. I'll give you quickly some examples of things that became difficult for me. Going to talks, which I love, until I got this, which was a year ago, a mini microphone. I was singing in a choir and hearing the instructions from the choir master. I wrote down here doing things and being, just those things. And then the discovery of background noise and how difficult that can be when you've got amplified sound with the hearing aid. That's almost the end of the negative bit, because out of it I've been transformed. And I'm going to tell you some of the things that I do. I expect you'll be impressed with the quantity and you'll be impressed with me, but I don't want you to be impressed with me. I mean, what I want you to think about is the angles I'm presenting to you of what I've done. And imagine 10 people doing these. And imagine yourself doing only one of them. Forget about me as the person who did them, okay? So the first thing, oops, I forgot. Oops.
Time ticking away. Take your time, don't worry.
Don't worry,
We'll
don't
give
worry.
it time.
Oh dear, now I'm shaking. Okay. So I started volunteering for Action on Hearing Loss. It had just changed its name from the RNID. And I went to the editor and said, there's a book that you should be reviewed in your magazine. And she said, okay, review it. So now I have a regular column for this magazine. I wrote this cover story about Richard Alston. He's a choreographer, at least as old as I am, with his own company, who lost a lot of his hearing, just became a sir, and he agreed to let me interview him about how he manages. Then, I don't know if you've heard about Lewis Vaughan Jones. He's a BBC newsreader, I think ITV as well. And he lost his hearing suddenly, like me, and he went public about it. And most people, or many people in the public eye, don't want anybody to know about them because they're afraid they'll lose your job. So he tweets about it, he blogs about it, and he let me interview him for the magazine, and he told his story. So this magazine is my way of telling people with hearing loss, and for everybody who subscribes, there's a family member who reads the magazine as well, things that they don't know that make their life more interesting, I think, if they read it. They never tell me they have. So that's just a kind of a contribution that I'd like you to think about. There's ways of publicizing things, there's ways of thinking about things that you discover and you can develop out of the blue. Then there's the James Lind Alliance that Helen has been telling us about. It was great to be invited. It was great to meet Helen and all these professionals and to be able to talk the lingo and learn the lingo. But even greater than that was the feeling that I was just one, but it was really a movement of bringing in of people like me what we thought, what we'd experienced. It's so unusual, don't you think, in research? So my question for you is what would it be like if patients originated all research? Okay, we know there's technical things that patients can't do, but just think of it that way. Think if you're doing research, if you have the patients with you from the very beginning. Then I was asked to be on a steering group to do with tinnitus. Is there anybody who doesn't know about tinnitus? Okay, I expect you probably know there's nothing you can do about tinnitus, right? You can't, there's no known way to make tinnitus not be. Well, this was a group that was looking for patient choices, an option grid of treatment when you have tinnitus. Now, it's crazy because all the choices you make may not take away from having tinnitus. All the same, if you participate in your own treatment, if you understand what the treatment is, what its limitations are, and what it might add to you, then it's more empowering than just being a victim of that sound. And so my question for you to think about is when there's no choice, is there really no choice? Or could you look for something beyond? The next thing was Clark. You may know about that. It's finished now. It's ARC, but it's Collaboration for Leadership in Applied Health Research and Care. And I got a fellowship to look at hearing loss. Basically, I said I want to have a fellow as a patient, along with all of you medical professionals, to do with hearing loss, and what I'm going to do in a year is change the world. And they gave me the fellowship. Basically, what I did while I was there was infiltrated the NHS with hearing loss. Because whatever organization I was at, I would say, I can't hear, could you do this? How do you do that in your own settings? And there were so many offshoots. One of the tutors managed, well, that's not the word, was a consultant in an acute ward. He had me in to train his junior doctors of what could go wrong in an acute ward for people with hearing loss. You can be mistaken for having dementia. You can be not addressed directly. You could come suddenly into hospital without your hearing aids. You could come with your hearing aids, but they wouldn't be noted and they could be lost. You could be functioning very well, but you wouldn't have batteries. You're used to somebody else changing the batteries, but they don't know how to change them. So that was a project that raised some people's awareness. Then I looked at hearing loss in care homes. I thought, how do we know about hearing loss in care homes, really? Who comes back and tells us? So I went and stayed in a care home as a pretend resident in 2 different care homes, monitoring what it was like to have hearing loss. I want you to think about the empathy that I did and the empathy that maybe you've not thought about in your own work in order to really get a direct experience. I can tell you it was traumatizing. Because I walked in, I had a suitcase, I'd arranged it with the managers. However, as soon as I was admitted, I had dementia. Yes, Terry, would you like to put this little picture here? And I felt it, That communication wasn't considering, they didn't know I had hearing loss, but imagine they are thinking that I'm demented even without the hearing loss, you know, and those two get confused. Then with that experience, I joined a group of NHS England as a patient that's looking at the need for better sensory health, especially among the elderly. And so we're looking at vision initially and hearing loss. And I was able to feed my experience into that ongoing process. That's another thing I've learned as a patient, maybe even as research. You go in and out of things if you're open to them. You don't never know really your impact, but you're there. So I think this is a demonstration of finding opportunities where there were none, just maybe creatively looking for ways to see things differently. As I speak, in London, there's an event going on called Hearing Birdsong. This was something that started with the sandpit innovation. Does that ever heard of sandpit innovations? They're like hackathons. Do all of you know one or the other? Yeah? It's an event where you come together, a bunch of people, and you try to come up with an idea that can be taken forward for research, for anything, usually involving technology. I co-produced the event with a person involved in patient safety, and what we were looking for were innovations in the treatment of people with mild to moderate hearing loss, with health and social care professionals. And what won was this guy who wasn't even intending to come, who listened to a woman who said that she only got her hearing tested when she realized she couldn't hear birdsong. He's developed bird boxes with birdsong of different pitches. The event went on to win £20,000 more, and today it's being realized. The members of the public in a part of London are being herded in with free coffee and asked to listen to different boxes which have different pitches of different birdsong, and then offered free initial screening. And I've just had a text saying that it's going well. I think that illustrates the idea that you don't really know where your career is going until you try something. For this man, he's now involved with hearing loss. When he started, he was just a friend of somebody who came along who had tinnitus. Now, do I have time? I have about 3 more personal examples. Yeah? So one is something called oral diversity, AURAL diversity. There's the University of Leicester, a man named Andrew Hugill, Hugill, and another academic came up with the term. You know, we've got biodiversity, we've got neurodiversity, gender diversity, but this kind of diversity is the most obvious, that we all hear differently. And his mission is that we don't necessarily look at hearing loss as an impairment. Yeah, it is, okay. However, what are the strengths? So he organized a 2-day conference and had 2 concerts. In the concerts, you could listen by putting your teeth on a vibrating thing. You had earphones that took out the background noise. You could walk in and out. There were certain pieces that were played that you could be asked to pling or whatever. It isn't music as we think of it, but I think it's a wisdom that he's suggesting that we need to look at hearing differently and at all of us. And the work and the conference there was a man who's doing a doctorate who's hard of hearing, who's writing about passages in literature describing sound because he finds that therapeutic. There's a man who, like me, lost his pitch. I did. I'll say that in a second. He's a musician. He is such a good musician that although he can't hear music and recognize it, he can accompany people because he can read music. And he hears it wrongly, but he can do it. Another thing is that I had hearing therapy. This is a field where there are fewer and fewer people, and I would like you to think about that and think how important it can be. I was given balance exercises. See if I can do it. Yeah, I couldn't do that before, one foot in front of the other. I was given a lot of philosophy about my anger. So this wonderful woman said, don't be mad at musicians. It's not their fault. They're giving you something. When I left, I was more resolved and more comfortable because a year and a couple of months ago, I suddenly lost low sounds and the pitch in my 2 ears changed. Tell me, raise your hand if you have heard of diplocusis. 1? Oh my God. 2? Yeah. Okay. Sad bit. I went to a lecture about tinnitus and hyperacusis, a whole afternoon. The wonderful lecturer, at the end I went up to him just waiting to say, what have you done on diplocusis? There's so many acusises, you know. He said, I don't really know what that is. What it means is you're in a room of untuned instruments when you're hearing an orchestra. They all go against each other. Now, there's no research on it. You don't know about it. So my question is, if you don't, it matters, right? You think it matters for me to be able to hear music, to sing, to play piano? Okay, so in order to get to a point where diplocusis matters, the earlier research has to be done. Get there. Help us do that research. So, in conclusion, I'm going to give you some suggestions based on what I've said to you today. Question your assumptions and your methods and your biases. For example, like I said with tinnitus, the assumption is you can't do anything, so why do anything? Consult experts, and don't assume that the expert in the room is the person with the most letters after their name. So Clark took me in as an expert on something they didn't know about, hearing loss. Consider problems laterally and creatively, like the magazine. Don't let problem solving come at the cost of asking the right questions. That's JLA. Invest in research with an open mind. Who knew we would get birdsong, you know? Look for links in and outside of your research and areas of knowledge. I can't remember the example of that. And finally, if you're doing research on one area, might it also involve, unbeknownst to you, hearing loss? That's it. Questions?
Do you have any questions? Z?
No? You could use my... Okay.
I think you've answered them all, Jean.
Yeah.
I think you've answered all of the questions.
I keep forgetting this. I just destroyed it.
So, Peter.
Well, can you hear me? Oh, great. Thank you very much for your talks. It was impressive. Okay? Great. Well, really good job, very important job in hearing loss research. And I wanted to design an activity to close this event today around these 5 things: communication with health professionals, access to health services, multimorbidity and healthy aging, primary prevention of hearing loss, patient safety and quality of care. The aim of this activity is not to identify the questions, as they have already done, but to identify the people that could work and move and put these ideas forward to real work. So I designed the activity based on the Snowball method. This is like a group brainstorming activity where we will all have, I have designed 5 minutes, but we can do that briefly, 3 minutes time. It's a very rapid activity. And we will assign each one of these 5 themes for each group. You can see already in the tables the wooden clipboards with the name. So please go and sit where you can see post-it notes. You can go to another table to sit there. And we will assign each one of these 5 things for each group to focus on for 3 minutes and write down ideas on each wooden clipboard using the post-it notes. Don't filter, don't overthink. You can write down whatever comes to your mind within these topics that represents an issue that you would experience if you were a patient with hearing loss, or any topic that can be linked with the research you are already involved in. An example, let's say that a researcher has previous experience in the barriers in access to health services faced by minority groups. So the person could add a post-it in the relevant theme, which is called access to health services, saying barriers, population from minority groups with hearing problems. Each group, after the 3 minutes, will be assigned the second clipboard to add on the ideas already written from the previous groups so as to have a cumulative effect. The point is to gather input from all the delegates, to exchange ideas and identify overlapping areas for research so as to nurture future collaborations. What will happen next? After the end of the activity, we will sum up the results of each wooden clipboard in 1-2 minutes. And after the event, I will send to all a follow-up email with a list of all the results, all these raw phrases that have been generated. And I will ask for more to indicate, for example, in a Google form, they're willing to be involved in working groups that will put these ideas forward to the research life cycle so as to define appropriate research questions and design the relevant project. So we want to identify the people, write any topic without overthinking within these 5 themes, then we will sum up the results and you will receive a follow-up email to indicate your interest in forming groups to take these ideas forward.